This seminar is on community-acquired pneumonia, both in adults and children. It is the most common infectious cause of hospitalization and mortality in adults in the United States. Community-acquired pneumonia is defined as pneumonia that is occurred outside the hospital setting or specifically in patients not hospitalized during the 48 hours before the diagnosis. Community-acquired pneumonia is typically treated in outpatient settings. Up to 10% of the patients with CAP are hospitalized. In the United States, there are 1.4 million emergency department visits for pneumonia. Out of that, 740,000 hospitalization, 41,000 deaths per year, and it cost 7.7 billion in inpatient costs alone. Most importantly, 30-day mortality after hospitalization for CAP varies from 2.8% for adults younger than 60 years to 26.8% for those aged 60 years and above with comorbid conditions. Children in low and middle income countries, the data is from 2015, 700,000 children younger than 5 years died from pneumonia worldwide per year. And also there is a national difference. Under 5 pneumonia mortality in Finland, only 0.65 deaths per 100,000 deaths. In Somalia, it amounts to 546 deaths per 100,000 deaths, which is 1,000 times higher than the incidence in Finland. According to World Health Organization, number of deaths caused by pneumonia exceeds that of AIDS, malaria, and tuberculosis combined. Let's talk about etiology in children. In children less than 3 months, the viral pathogens predominate, and the most common being RSV, influenza, and human metapneumovirus. Among bacterial pathogens, group B streptococcus is the most common, followed by gram-negative bacilli such as E. coli, strep pneumonia, and pertussis and chlamydia trachomatis. In children 3 months to 5 years, again RSV, influenza, and human metapneumovirus and parainfluenza dominates, and followed by, in the bacterial side, strep pneumo, mycoplasma, staph, and H. flu plays a dominant role in the causation of CAP. In children more than 5 years, influenza, human metapneumovirus, and adenovirus are the most common viral causes of CAP. And as you can see, mycoplasma becomes a predominant organism in causing CAP, followed by strep pneumo, staph, group A strep, and H. flu. And causative organisms in adults similar to adults, children above more than 5, strep pneumo, staph, H. flu, and anaerobes. Even among viral causes, there is no big difference between children and adults. It's most commonly caused by RSV, influenza virus, and human metapneumovirus. This data is from EPIC trial published in 2015. The causative organism for hospitalization in adults. As you can see, in 62% of the cases, there are no organism identified. Then again, major chunk, about 22% of the patients, just viral pathogen was isolated, and the bacterial cause only 12% and another 2-3% of bacteria as a co-infection in the viral primary CAP. And also another thing came out of EPIC trial was there is a seasonal increase in CAP, more common being during winter months, starting from middle of November all the way up to the end of March. This data is from United States. The newer pathogenesis questions the initial assumption of the lower respiratory tract is completely divide up in your organism, then one organism, either staph, H flu, or a staph, goes and infects. That has been challenged with this new paradigm. Actually, the lower respiratory tract is continuously exposed to different pathogens, bacteria, virus, and fungi. They're continuously exposed to microbe, but because of the underlying immunoprotection, they don't develop infection. Things like alveolar macrophages, airway epithelial cells, and mucociliary actions continuously remove the bacteria or infectious organisms from the lower respiratory tract. Same token, when there is a defect in the mucociliary clearance, that can happen in smoking, chronic airway disease, and air pollution, and when there is a defect in the cough, as happen in neuromuscular disorders, chronic airway disease, and substance abuse, where the cough reflex itself is affected, or phagocytic elimination of microbes or impaired, as in the case of aging, smoking, usage of steroids, alcohol abuse, air pollution, and nutritional deficiencies, and other adaptive immune response impairments that prevents the normal clearance of infectious agents from the lower respiratory tract. Other factors like nutrient availability, host-derived molecules, and immune cells, again impaired, they inhibit microbial reproduction. When there is a defect in any of those nutrient availability, host-derived antimicrobial molecules, and microbial virulence factors, if it is high enough to supersede the underlying immunoprotection, then that particular organism reproduces more and causes infection, inflammation, and so on and so forth. So, what are the signs of respiratory distress in children? One, tachypnea. Based on the age, the rate of respiratory differs. Respiratory rate in less than 2 months, more than 60, 2 to 12 months, more than 50, 1 to 5 years, more than 40, and more than 5 years, more than 20. Along with that, dyspnea, retractions with suprasternal or intercostal subcostal based on the severity, grunting, nasal flaring, apnea, altered mental status, and pulse oximetry less than 90% on room air can be seen in patients with in children. This is the data published in JAMA in September 2024. As you can see, none of them, respiratory symptoms, respiratory signs, and infectious signs in patients with pneumonia, is not 100% sensitive or 100% specific. As a result, to make a diagnosis of pneumonia, you got to have infectious signs like more high temperature, leukocyte, either leukopenia or leukocytosis, or more than 15% of bands, or one of the signs of respiratory signs like hypoxemia, auscultatory findings, or tachypnea, or symptoms such as cough, adverse change, or increased sputum production, new or increased dyspnea. So any of these needs to be happen together along with X-ray features, X-ray chest features, to make the diagnosis of pneumonia. This particular chest X-ray is a normal one. As you can see, the adjacent one shows bronchopneumonia. This is caused by strep pneumo in this case. This is radiologic images of 2-year-old with a large parapneumonic effusion caused by strep pneumo. This X-ray chest is complete opacification of right side of the chest, and the X-ray CT chest confirm that one. This is another radiograph of 2-year-old boy with pneumococcal pneumonia with bacterium demonstrates consolidation of right lower lobe infiltration, with obliteration of the right hemidiaphragm. So there is some effusion. The next one is 6-year-old boy with multilocular multilobar pneumonia caused by MRSA, methicillin-resistant Staph aureus. As you can see here, you see a small pneumatoceles that is often seen in patients with staphylococcal pneumonia. This X-ray shows the round opacification, and further confirmed by CT scan, this is the case of lung abscess caused by MSSI, methicillin susceptible Staph aureus. The CT scan is not routinely recommended. It is recommended only to find out the complications or if the examination does not match with the clinical signs and symptoms, then CT chest is recommended. Ground glass opacities you can see in patients with pneumocystis, mycoplasma, fungi, CME, and other viruses. And tree in bud pattern reflects presence of bronchioles filled with inflammatory material seen in bacteria, mycobacteria, fungi, viruses, including RSV and parainfluenza, and other atypical organisms. Next is diagnostics testing for community-acquired pneumonia. There are a bunch of them are recommended or being done in United States. I will go one by one. What are the reasons for it and why do you need it and how that one help? It's starting from COVID testing and COVID and influenza testing, cultures, respiratory culture, MRSI, pneumococcal urinary antigen, Legionella testing, Procal, and extended respiratory viral testing, and invasive lower respiratory tract diagnostic testing like bronchoscopy. First, this is routinely done in United States emergency departments, and the patient comes as pneumonia. Automatically they are screened or tested for COVID-19 and influenza. IDSI, Infectious Disease Society of America, recommends the virus testing needs to be done in all the patients. Number one, to isolate. Number two, to treat them adequately with antivirals. The second testing is MRSA nasal swab. This is recommended only in severe community-acquired pneumonia and also when there is risk factors for methicillin-resistant Staph aureus. We will discuss in detail what are the factors that make the patient increase the risk for having MRSA at this person visit. So it's not routinely recommended for all community-acquired pneumonias. Blood cultures are recommended only for severe community-acquired pneumonia or when there is a risk factor for MRSA or Pseudomonas or when there was empirical treatment was started with the antibiotics, so MRSA and Pseudomonas. So that will kind of help us once the culture is positive for MRSA, you can continue to give MRSA. If it is negative, you can stop. And the same way the Pseudomonas. Respiratory culture is recommended for severe community-acquired pneumonia, risk factors, and also risk factors for MRSA and Pseudomonas, or if the empirical treatment for MRSA and Pseudomonas was started in patient with CAP. Pneumococcal urinary antigen is not routinely performed, but it is recommended only in severe CAP. It's not recommended in ambulatory settings and also in non-severe CAP. The idea of doing pneumococcal urinary antigen again to narrow the antimicrobial agent. But anyhow, most of the patients with severe CAP automatically started on beta-lactam therapy that is works against pneumococcal, but that will having pneumococcal urinary antigen further narrows down only the beta-lactam alone enough in patients with community-acquired pneumonia. Legionella again recommended in severe CAP or when there is a risk factor for Legionella like non-exposure or travel, or setting of outbreak. Procalcitonin is recommended only in severe community-acquired pneumonia and also to guide the antibacterial initiation or discontinuation in combination with other viral agents. So it is very useful tool in initiation and tapering of antibiotics in severe community-acquired pneumonia. Expanded respiratory viral panel. IDSI recommends only for severe CAP or in combination with procalcitonin to guide antibacterial initiation or discontinuation. Let's go and let's talk about treatment for community-acquired pneumonia. Yeah, I think this slide is very crowded. I'll go one by one. So when you made the diagnosis of community-acquired pneumonia, as I told you, you need to have a chest X-ray, respiratory, the evidence for infections, either temperature, leukocytosis, leukopenia, or bandemia, and also the one of the sign of respiratory symptoms, along with chest X-ray positive. In the outpatient settings, this is adult data or the adult recommendations. In outpatient patients, amoxicillin or doxycycline alone is enough. If the patient has comorbidities like chronic lung disease or asplenia, amoxicillin clavulanate or oral cephalosporin such as cefoperoxime or cefuroxime and macrolide doxycycline. The fluoroquinolones is used only if the patient could not able to tolerate the previously mentioned agents or if they have allergic to those previously mentioned agents. In inpatient non-severe pneumonia, its recommendation is beta-lactam antibiotics that could be ampicillin and sulbactam or ceftriaxone along with macrolide. Again, the fluoroquinolone is only indicated if the patient did not tolerate the medicine or if they are allergic to the beta-lactam and macrolide combination. In inpatient severe community-acquired pneumonia, the recommendation is beta-lactam plus macrolide. And again, fluoroquinolone is indicated only if they are allergic to or not tolerating beta-lactam antibiotics and macrolide. In hospitalized non-severe community-acquired pneumonia, empirical therapy with beta-lactam alone with ceftriaxone or beta-lactam plus macrolide. The recent data suggest, the ACCESS trial published this year suggests adding macrolide as an empirical therapy along with beta-lactam decreases severe sepsis by reducing inflammatory cytokines. Fluoroquinolone as a monotherapy is restricted because it can cause C. diff infection, antibacterial resistance, and the risk of tendon rupture. Macrolides in community-acquired pneumonia. The highest quality observational and clinical trial evidence suggests that macrolides can improve outcomes, potentially including mortality for severe CAP. 2024 ACCESS trial clearly states macrolides reduce the composite endpoint of respiratory symptom severity and early inflammatory response. So it is recommended to give a combo therapy as an empirical treatment for non-severe community-acquired pneumonia and also severe community-acquired pneumonia. This recommendation for adults, we do not have a recommendation for children yet, but I think it should work for children too. This is from the ACCESS trial. As you can see, the standard therapy is the red line and the blue line is the standard therapy plus macrolide. In this particular case, they used clarithromycin. As you can see, the difference between the first new sepsis episode significantly decreased when they add macrolide along with beta-lactam. Severe CAP. Empiric treatment is same as non-severe CAP, beta-lactam plus macrolide, fluoroquinolones, only if they can tolerate the beta-lactam macrolide combination or if they are allergic to. Empirical therapy with antibacterial medications such as metronidazole or clindamycin can disrupt gut commensal bacteria, like can cause C. diff colitis. It is associated with an estimated 5 to 6% higher mortality. So the 2019 ATS IDSA CAP guidelines does not recommend antibacterials against anaerobic bacteria. What are the problems with the empiric antibiotic therapy? There are studies done in almost like 1,500 hospitalized patients. 20% of them develop some kind of adverse event because of antibacterial medications. Single additional day of antibacterial treatment increase the absolute risk of acquiring resistant organism by 7%. That is, if the chances of acquiring resistant organism is 10%, it will make it 17% by increasing one extra day of antibiotic. In addition, the gut microbiome changes with increased exposure to antibiotic, that it has been linked to obesity, chronic inflammation, and cancer. When to use anti-MRSA coverage? In outpatient setting, there is no anti-MRSA therapy is recommended. Inpatient non-severe only if the respiratory isolation of MRSA or if risk factors and culture results return positive for MRSA. Only in those conditions empiric MRSA coverage is indicated. In severe CAP, with the prior respiratory isolation MRSA or recent hospitalization with parenteral antibacterial medications. When it is needed, use vancomycin or linezolid. These are all the recent recommendations for usage of MRSA as an empirical therapy. When to use anti-MRSA and anti-pseudomonal antibiotics. Severe CAP is more likely to have MRSA and pseudomonas. The incidence go up from 1% to 5%, 1% to 3%. Prior MRSA or pseudomonas infection or recent hospitalization with parenteral antibiotic exposure, that means in the last 90 days. Another important point is negative MRSA nasal swab test has negative predict value of 99%, meaning when the MRSA nasal swab is negative, the chances of the patient having MRSA as a causative organism is 99% less. Anti-pseudomonal empiric therapy. In outpatient, no coverage is recommended, similar to MRSA. Inpatient non-severe CAP, only if a prior respiratory isolation of Pseudomonas or if risk factors and culture results returns positive. Only in that circumstances in non-severe CAP, anti-pseudomonal antibiotics needs to be started. In severe CAP, with a prior isolation of Pseudomonas or recent hospitalization with parenteral antibiotics, only then the anti-pseudomonal antibiotics needs to be started. When needed, cefepime may be preferable to piperacillin tazobactam. Alternative agents are ceftaz, imipenem, or meropenem. COVID-19 and bacterial infection. Most patients with CAP did not require antibacterial medications because the bacterial co-infection occurs only in 3.5% of the patients. Procalcitonin will be helpful in determining bacterial co-infection in patients with COVID-19. The negative predictive value is so high so that will help you to avoid starting antibacterial medications in patients with COVID-19. But the positive predictive value is not that high. So if it is positive, it's not automatically the patient has a bacterial infection, but negative predictive value with a 99% certainty says it's not a bacterial infection. So non-COVID cap, like bacterial co-infection with non-COVID viral pathogens. In non-ICU patients, 7% had bacterial co-infection. That incidence doubles in ICU patients. The bacterial co-infection is 15%. Again, the negative predictive value of procalcitonin can help us which patient can get or should have antibacterial medications. The next question is how long one need to treat CAP. In outpatient settings, 3 days of antibiotics is good enough. Inpatient in non-severe CAP, again recommend only 3 days if the patient is stable by 3 days. What is the criteria for stability? The patient should be afebrile. This is an adult data again. Heart rate is less than 100, respirators less than 24. There should not be any hypoxemia, meaning oxygen saturation should be normal in room air. Systolic blood pressure should be normal. So in those patients, the recommended duration is 3 days. If the stability is reached at 5 days, then give antibiotic till 5 days. If the patient has an MRSA or Pseudomonas, and 7 days of antibiotics are recommended. Longer durations for complications such as empyema and unusual pathogens such as fungi. In ICU CAP, the patient admitted to intensive care excluded from the duration of clinical trials, so we do not have recommendation for ICU community-acquired pneumonia. As far as outpatient, 3 days, inpatient 3 to 5 days, and 7 days for MRSA and Pseudomonas, longer durations for complications or unusual pathogens. Given the potential harms of longer antibacterial duration, clinicians should treat patients with the shortest effective duration. Outpatient, those who discharge from the hospital or ED should be treated with only 3 days of antibiotics. Patient who takes more than 3 days to clinically stabilize should generally receive a total of 5 days of antibiotics. Long durations commonly recommended for MRSA and Pseudomonas infection. Next is transition to antibacterial medications. The de-escalation of antibacterial medication includes stopping the bacterial medications, stopping the antibiotics, or transitioning from empirical to directed therapy, or narrowing the spectrum of therapy, or transitioning from intravenous to oral antibacterial medication as soon as the patient can ingest oral medication. The recommendations are amoxicillin clavulanate 500 mg 3 times a day, or when you use 875 mg twice a day, cefoperoxime 200 mg twice a day, cefuroxime 500 mg twice a day, or amoxicillin 1 gram orally 3 times a day, plus 1500 mg of azithromycin. This is for children. In children less than 5 years of age, for presumed bacterial, oral amoxicillin 90 mg per kg per day in 2 doses, or augmentin, which is amoxicillin clavulanate 90 mg per kg per day in 2 doses. So as you can see, in children, we do not have that recommendation like beta-lactam plus macrolide. Here they go with presumed bacterial, you treat with amoxicillin or augmentin, presumed atypical Citromax or azithromycin 10 mg per kg per day on day number 1, followed by 5 mg per kg per day for days 2 to 5, or oral clarithromycin 15 mg per kg per day in 2 divided doses, or oral erythromycin 40 mg per kg per day in 4 doses. In inpatient all ages, if the patient is immunized against strep pneumo, H flu, and local level of antibiotic resistant to strep pneumo, if it is presumed bacterial, ampicillin, penicillin, ceftriaxone, or cefotaxime can be treated, and one can add vancomycin and clindamycin for suspected community associated MRSA. So we do not have a strong recommendations as we had seen in adults, but this is how we practice. Mostly we do ceftriaxone and vancomycin together, sometimes clindamycin. The kind of adult, they already gone out of clindamycin. Presumed atypical azithromycin, add beta-lactam if diagnosis of atypical pneumonia is in doubt, only then they add. Or clarithromycin or doxycycline for children more than 7 years, or levofloxacin for children who have reached growth maturity or who cannot tolerate the previous antibiotics. The recommendation in children is definitely lagging behind in adults. The patient is more than 5 years of age, if it is presumed bacterial, the recommendation is similar: amoxicillin or augmentin, same dose, 90 mg per kg per day in 2 divided doses to the maximum 4 gram per day. The same thing for augmentin. It is a presumed atypical oral azithromycin similar to less than 5 years, 10 mg per kg on day number 1, followed by 5 mg per kg per day, 2 to 5 days. Or clarithromycin 15 mg per kg per day in 2 divided doses, or erythromycin or doxycycline if the child is more than 7 years old. If the patient is not fully immunized against strep pneumo, H flu, or high local level antibiotic resistant to strep pneumo, then the antibiotic choices are for presumed bacterial pneumonia, ceftriaxone or cefotaxime, and the addition of vancomycin or clindamycin for suspected community associated MRSA. Alternatives are levofloxacin, addition of vancomycin and clindamycin for suspected community associated MRSA. If the infection is presumed atypical, the azithromycin or doxycycline, if the child is more than 7 years old, levofloxacin can be given for those patients who have reached growth maturity or who cannot tolerate macrolides. Let's talk about usage of steroids and secondary prevention. Now, when to use steroids in CAP. In outpatient settings, there are no steroids indicated. In inpatient non-severe CAP, no steroids are recommended. In inpatient severe community-acquired pneumonia, steroids are recommended with the doses of 200 mg per day, that means 50 mg Q6, within 24 hours of meeting severity criteria. The reason being is the steroids have been shown to reduce the mortality, and also it reduces the need for mechanical ventilation, vasopressor use, and hospital length of stay or ICU length of stay. The adverse events not increased by steroids in patients with severe CAP. And also in COVID-19 pneumonia with hypoxia, usage of dexamethasone 6 mg daily for 10 days reduces 28-day mortality. In non-COVID-19 with severe CAP, yearly administration of steroids can reduce the mortality up to 5.6%. And also it reduces the need for mechanical ventilation, vasopressor use, and length of stay. In non-severe CAP, there are no benefits from steroids, so steroids are not indicated in ambulatory setting and also in non-severe CAP. The secondary preventions are: number 1, vaccination. So for outpatients and inpatients, for all eligible vaccinations needs to be given before discharge, especially against pneumococcal, influenza, COVID, and RSV. And the patient needs to be screened and treat tobacco use, including cessation of counseling and medications. Third is general aspiration risk, like dysphagia, alcohol abuse, and oral health. Screen for and treat alcoholism and substance use disorders. Recommend good oral hygiene, including toothbrushing every day. If dysphagia, consider speech eval and therapy. Other comorbid management: ensure all cardiac, like heart failure, and pulmonary, like COPD and asthma, needs to be treated per guidelines with goal-directed therapy restarted before discharge. So, in summation, smoking cessation, avoiding alcohol, and relevant vaccination need to be addressed before the patient's being discharged from the hospital. Good oral hygiene, since it is the risk factor for community-acquired pneumonia, that need to be re-emphasized. Aspiration should be evaluated by speech and swallow therapy. How to avoid and reduce aspiration? Eating with small bites, fully chewing each bite, consuming small frequent meals, and sitting upright during and for 30 minutes after meals. Finally, we will end up with IDSA, a CAP clinical pathway. When the patient is diagnosed to have CAP, first assess whether the patient is hypoxia or not. If there is no hypoxia, consider outpatient treatment. If the patient is, this is an adult clinical CAP pathway. Children are a little different. Um, if the patient has hypoxia, inpatient admission, and divide the pneumonia into non-severe and severe. If it is non-severe, do a diagnostics testing, including viral diagnostics. If it is positive, start antiviral therapy and consider antibiotic deferral by using procalcitonin. If the severity shows severe CAP, again diagnostics testing, including viral diagnostics. If it is positive, start antiviral therapy and consider antibiotic deferral if there is low suspicion or bacterial co-infection, low suspicion of bacterial co-infection, for example, using procalcitonin level is lower. If the viral testing is no, then evaluate whether it is a non-severe category. MRSA non-severe CAP risk factors, whether the patient has MRSA colonization or infection of the respiratory tract. If it is present, then consider anti-MRSA coverage. If there is no, then evaluate for Pseudomonas aeruginosa non-severe CAP risk factors. That means underlying advanced structural lung disease or history of Pseudomonas aeruginosa colonization and infection within 1 year. If it is no, consider just beta-lactam and macrolide. If it is present, anti-pseudomonal plus atypical coverage. In the severe category, if the virus is positive, antivirals, and consider antibiotic deferral if there is low suspicion or if the procal is less. If the viral studies are negative, MRSA severe CAP risk factors such as hospitalization and parenteral antibiotic in the last 90 days, or history of MRSA colonization, prior MRSA isolation, especially from respiratory tract within the last 1 year. If it is present, add anti-MRSA coverage. If it is no, evaluate for Pseudomonas severe CAP risk factors, which are hospitalization and parenteral antibiotic 90 days, similar to MRSA, or history of Pseudomonas aeruginosa colonization or infection of the respiratory tract. If it is present, add anti-pseudomonal plus atypical coverage. If there is no, then beta-lactam and macrolide combination. Then once we started, then follow up need to be done as we are going to discuss in further slides. So how to make the diagnosis of community acquired pneumonia in adults, that means more than 18 years, without immunocompromising conditions. Newly recognized pulmonary infiltrate on chest imaging. So chest X-ray is a must, along with at least one respiratory symptom: new or increased cough, new or increased sputum production, dyspnea, and pleuritic chest pain, or at least one other signs or findings like abnormal lung sounds, temperature more than 100.4, or leukocytosis or unexplained anemia or hypoxia. So you got to have all the three to make the diagnosis of community acquired pneumonia. Then how to make the diagnosis of severe CAP? They have to meet one major criteria or three or more minor criteria. The major criteria are septic shock with need for vasopressors, respiratory failure requiring mechanical ventilation. The minor criteria are respiratory rate more than 30, this is an adult, PF ratio less than 250, multilobar infiltrate, confusion or disorientation, uremia, that means BUN is more than 20, leukopenia less than 4,000, thrombocytopenia less than 100,000, and hypothermia, core temperature less than 36, hypotension requiring aggressive fluid resuscitation. So if the patient fulfills severe CAP, then you need to evaluate them differently and treat them aggressively with appropriate antibiotics as per guidelines. Regarding diagnostic testing for CAP, blood culture is not routinely recommended for non-severe CAP, but is recommended for severe CAP. Procal is considered if available and recommended by the hospital guidelines. In severe CAP, it is recommended by hospital guidelines. Respiratory culture is not routinely recommended for non-severe CAP. It is recommended for severe CAP. It is recommended in non-severe CAP only if the patient received parenteral antibiotic for hospitalization in the last 90 days, or anti-MRSA or anti-pseudomonas coverage is initiated, or advanced structural lung disease. Only in those conditions, respiratory culture is recommended in non-severe CAP. Molecular testing for bacterial pathogens not routinely recommended in non-severe CAP. In severe CAP, if it is available and recommended by hospital guidelines. MRSA nasal swab, it is recommended for non-severe CAP if hospitalization and received parenteral antibiotic in the last 90 days, or anti-MRSA coverage is initiated. In severe CAP, again the same guidelines: hospitalization, parenteral antibiotic for last 90 days, a history of MRSA colonization or infection at any site within the last 1 year, or anti-MRSA coverage is initiated. Influenza testing, yes, needs to be done if the virus is in the community, travel risk, or potential exposure. That is true for both non-severe and severe. COVID-19 testing, similar recommendation for both non-severe CAP and severe CAP. Expanded molecular testing like rhinovirus, adenovirus, and respiratory syncytial virus, consider if it is available, and in severe CAP, yes, if it is available. Legionella urinary antigen test, if there is a recent outbreak, travel, or epidemiology factors in non-severe category, and they recommend for all severe pneumonia in adults, Legionella urine antigen test. Pneumococcal urine antigen test recommended for severe CAP, not routinely recommended for non-severe CAP. Then how to select antibiotic. In non-severe CAP, use beta-lactam antibiotics plus macrolide. If the patient didn't tolerate or allergic to above beta-lactam and macrolide, choose levo or moxi. This is a standard regimen. When there is a recent hospitalization with parenteral antibiotic in the last 90 days, again beta-lactam plus atypical coverage, same as standard regimen. When there is a history of MRSA, this is for non-severe CAP. History of MRSA colonization or infection at any site within 1 year, or MRSA nasal PCR is positive, Add vancomycin or linezolid. And history of Pseudomonas colonization and infection at any site within last 1 year or advanced structural lung disease. In non-severe CAP, I either use piptazo, cefepime, ceftaz, imipenem, or meropenem. The macrolide choices are zithromax, clarithromycin, and doxycycline. In severe CAP, again, it's recommended beta-lactam plus atypical coverage for empiric therapy. MRSA coverage, choose vanc or linezolid based on the hospital guidelines. Beta-lactam plus atypical coverage, this is for anti-pseudomonal, piptazo, cefepime, ceftaz, imipenem, meropenem, or one of those macrolides. MRSA coverage, we already talked about it, and beta-lactam plus atypical coverage, the similar. The only thing is the criteria are a little different for severe CAP antibiotic recommendations as well as antibiotic choices are very similar, non-severe inpatient versus severe inpatient. Next is assessment. Confirm CAP diagnosis and assess clinical improvement. Review clinical progression to confirm CAP diagnosis versus non-infectious etiology. Evaluate documented penicillin allergy as recommended by hospital guidelines. The evaluation may include history and physical examination, allergy consultation, challenge doses, or skin testing. And assess for clinical stability by using Tmax, heart rate, respiratory, saturation, baseline mental status, and blood pressure more than 90. And also assess for CAP complications if there are no clinical improvement. Determine pathogen-directed therapy based on sputum culture. Viral diagnostic, consider discontinuing antibiotic if viral diagnostics are positive, or procalcitonin is less than 0.25, or white cell count less than 10,000, or low suspicion of bacterial co-infection. MRSA nasal swab. If negative, discontinue MRSA coverage. If positive, may not be indicative of MRSA pneumonia. Continue assessment for other MRSA risk factors and consider anti-MRSA therapy discontinuation if no risk factors. Treatment consideration, try to minimize broad spectrum antibiotics when possible and assess for adverse drug events. Next is discharge considerations. Assess for clinical stability. Patient afebrile with at least 5 signs of CAP stability criteria listed above or return to baseline. And assess for ability to tolerate oral therapy or de-escalation options. If there is no risk factors for multi-drug resistance, use amoxicillin clavulanate 500 mg 3 times a day or amoxicillin clavulanate 875 mg twice a day, cefoperoxime 200 mg twice a day, or cefuroxime 500 mg twice a day. When there is multi-drug resistant risk factors, use levo 750 mg every 24 hours. If Legionella negative or alternative etiology identified, discontinue Zithromax after 1500 mg total. Consider duration of antibiotic administered no more than 3 to 5 days in total in the emergency department and inpatient if clinically stable by day number 3. Ensure post-discharge follow-up including insurance coverage and availability at outpatient pharmacy. Consider vaccination especially for pneumococcal, influenza, COVID-19 and RSV. If relevant, provide smoking cessation, counseling, medication and ensure the patient is on a proper therapy to enhance control of chronic conditions like COPD, asthma and cardiac failure. Educate patients and caregivers. Planned antibiotic course and instruction follow-up medications. Signs and symptoms of worsening infection and sepsis. Signs and symptoms of antibiotic-associated adverse events including C. diff infection. Adjuvant therapies like use of statins, activated protein C, non-invasive ventilation, anticoagulants, immunoglobulins, probiotics, chest physiotherapy, cough medications, and beta agonists. None of them have been shown to have a significant role in CAP therapy. Thank you so much for listening to this seminar. And as we promised, we do seminars every Sunday on the important topics affects both adult and children. It will be sharply start at 6 p.m. Indian time and 6:30 a.m. Central Standard Time, United States. See you next week.